Acute abdominal pain in a 45-year-old male with recurrent pancreatitis and chronic comorbidities by Zoe Jeffries and Dana Josifoski. JR is a 45-year-old male with a significant past medical history of recurrent pancreatitis, end-stage renal disease on hemodialysis, uncontrolled diabetes, uncontrolled hypertension, hyperlipidemia, coronary artery disease, status post stents to the LAD, and HIF-ref with an ejection fraction of 41%, who presents to the ED with abdominal pain, shortness of breath, and chest pain. An hour after eating a meal, he went to bed and was awakened with shortness of breath. Patient states he has central chest pain that is non-radiating, pressure-like, and 8 out of 10 in severity. During similar episodes in the past, he has taken isosorbide dinitrate, which relieves the pain. The patient reports having epigastric pain that is postprandial in nature and radiates to the back. It is 8 out of 10 in severity. Patient states he has been having chronic nausea for the past 3 years associated with decreased appetite. He denies fever, chills, dizziness, lightheadedness, vomiting, and diarrhea. On review systems, it is significant for positive for decreased appetite and diaphoresis, as well as positive for cough, shortness of breath, and wheezing, positive for chest pain, and positive for abdominal pain and nausea. A more thorough past medical history includes asthma, HIF-ref, COPD, type 1 diabetes, diabetic neuropathy, end-stage renal disease on hemodialysis, essential hypertension, gastroparesis, chronic pancreatitis, anemia of chronic disease, seizure disorder, GERD, and a history of DVT. Past surgical history is significant for amputation of left foot big toe 2019, amputation of right foot below the knee 2020, AV fistula placement, and calcanectomy of the heel. He has no known drug allergies. He is on albuterol, aspirin, atorvastatin, budesonide formoterol, clonidine, clopidogrel, gabapentin, hydralazine, Norco, Novolog, Lantus, isosorbide dinitrate, lacosamide, losartan, metoprolol succinate, nifedipine, pantoprazole, calcium acetate, ferrous sulfate, and a multivitamin. Family history includes hypertension in the mother and kidney disease in the father. And social history, he has no alcohol use, was a former smoker, and uses cannabis 2 to 3 times a week. His vitals include a blood pressure of 180/88, pulse of 100, respiratory rate of 20, and temperature of 97.9. His physical exam is significant for wheezing on auscultation of the lungs, as well as acute respiratory distress, and epigastric abdominal tenderness. His labs, his AST and ALT were unremarkable. His lipase was elevated at 245. His WBC count was at 3.5, and troponin has been stable, ranging from 45 to 41.
So for our differential diagnoses, we have our top 3. Patient has obviously a lot of medical comorbidities that can make this clinical picture a bit clouded. So first, we thought pancreatitis. He's had it in the past before. He's presenting with epigastric pain and elevated lipase. Second, chronic mesenteric ischemia. He has multiple risk factors for this, and he's presenting with postprandial abdominal pain and nausea. And then lastly, and potentially the most dangerous one, would be aortic dissection. Given this patient's high blood pressure and chest pain, the team wanted to rule out an aortic dissection by ordering a CT angiogram. So these are the results of the CT angiogram that was done. We have it zoomed out on the left, and on the right, I've blown up the image that's focused on the abdominal area. And so first, for our impression, there is no acute aortic pathology. And then second, as indicated by the yellow arrow in the right image, we see high-grade stenosis of the origin of the celiac artery with a J-shaped configuration of post-stenotic dilatation suggestive of median arcuate ligament syndrome. So upon incidentally finding median arcuate ligament syndrome, we consulted vascular surgery, who then ordered a duplex ultrasound of the abdominal area, and the findings are indicated on the right. And so this ultrasound is showing significant narrowing or stenosis of the celiac artery, and with blood flow is speeding up and becoming turbulent, and we see this as a sign of narrowing. So during inspiration, the blood flow slows down, suggesting that the artery is less compressed, and the velocity of the blood flow is highest during rest. But when the patient inhales, the flow slows down, suggesting that the compression is relieved. So the colors on this Doppler represent the direction and speed of the blood flow, with the color mixing areas in the center indicating areas of turbulence, further confirming findings for median arcuate ligament syndrome. So our final diagnosis is median arcuate ligament syndrome. So, this is a rare condition in which the medial arcuate ligament, which is located under the diaphragm and the abdomen, compresses the celiac artery, thus impairing blood flow to the stomach, liver, and other organs, causing chronic abdominal pain that can occur with eating or exercise, and can also cause, in more extreme cases, chest pain or even pancreatitis, as our patient has had. The treatment for MALS is often with surgery. So, with our patient specifically, we consulted vascular surgery, but they believed that the patient was not a good candidate for surgery given all of his medical comorbidities. So, pain management was consulted, and the primary team managed his nausea. Ultimately, the patient was dissatisfied with this outcome and eventually decided to leave against medical advice.